talk about dementia. Interestingly, in the medical setting, in the professional setting, we are moving away from the term dementia because it has developed a negative connotation. My children repeatedly remind me that I'm demented. And so the Diagnostic and Statistical Manual, fifth revision of the American Psychiatric Association came up with a new term, which is severe neurocognitive disorder, to describe specifically what we are going to talk about today and which we refer to as dementia. And I appreciate this change because my children find it difficult to pronounce these words, severe neurocognitive disorders. So they tend to give me a break. But dementia is an acquired deterioration in your mental condition to the extent that you are no longer able to carry out your normal activities of daily living. Those who have always been like that, always have problems with memory, always having problems with coping with activities, they are not demented. They are likely mentally retarded. Now, so most people with dementia would have had normal cognitive function at some time. And then, as a result of varying medical maladies, they develop a deterioration in their cognitive functions. Shireen mentioned that Alzheimer's disease is considered worldwide as the most common cause of dementia. Interestingly, in Jamaica, where I reside, small strokes in the brain is the most common cause of dementia. In other areas of the globe, I know in Sri Lanka that Parkinson's disease related type issues also contribute significantly to the incidence of dementia. So the main cause of dementia in your local location may be different from Alzheimer's disease. Shireen mentioned that every 3 seconds, someone else is diagnosed with dementia worldwide. She mentioned that the numbers are just over 55 million now, expected to increase drastically. And every year we have to review these projections because we're always moving ahead of projection. 10 years ago, we were going towards $1 trillion spent on dementia care per annum. Now it's 1.3 trillion, expected to increase by 2030 in another 7 years to $2.8 trillion. That's a lot of money. That's greater than the annual budget of many countries, including Indonesia and such large countries. So when we look at dementia, we should remember not all persons will have a decrease in their mental function as they grow older. Most persons will continue to enjoy relatively normal cognitive performance. A small subset of people will at some time begin to notice that they're not remembering so well or they're forgetful and so on. And at some point, others may begin to notice this. That condition where people realize that they are no longer remembering very well and others corroborate is called mild cognitive impairment. These persons, however, are able to carry out their normal activities of daily living. And then over time, this condition may deteriorate to the point where persons are no longer able to carry out their normal activities, their shopping, their accounting, and so on. It is at that point that we refer to them as having dementia. This is the point when we refer to them as having severe neurocognitive disorder. But as you can see on this graph, the process from the point where you begin to have minimal changes to the point where you qualify for the diagnosis of dementia can be many years. Please don't try and read this slide. I just want to remind you that I'm intelligent. So I have to put this slide up. The idea I want to convey is that people normally do not go to bed in good mental health and wake up with dementia the next morning. That's the first point. The second point is that the main contributor to dementia is not only your family history or your genetic makeup. Apparently, various traumas to your brain over your life course contribute and predispose you to dementia later on, regardless of your genetic makeup. So you might have had early trauma to your brain when you fell off a guava tree at the back of Ladies College in the recess. You remember that, Shireen? And then you would have hit your head and have a minor brain damage, which wasn't serious, but that was the first hit. And then you might have been exposed to toxins, insecticides throughout life. All these traumas to your brain contribute to you developing dementia, Alzheimer's disease, or other types later on in life, which is why we developed this approach of the Healthy Brain Project to try and protect your brain throughout life. I worry about agricultural societies like Sri Lanka, where a lot of pesticides and insecticides are used in the rural areas. Children work in these farms on their holidays and so on, and are exposed to these insecticides and pesticides. And so they begin to get hits in their brain earlier on in life. No wonder we have high incidence of not just kidney disease, but also other neurological conditions. And this is something that we need to pay attention to. So apart from that though, when we look at the risk factors for developing dementia and Alzheimer's disease in particular, we consider age, family history, your status of a lipid transporter protein in your blood, your gender, whether you have high blood pressure, high cholesterol, or diabetes, whether you smoke, whether you're physically and mentally active. These are some of the important known risk factors. Now, when we look at these risk factors, the 7 risk factors of diabetes, high blood pressure, obesity, smoking, depression, low education, and physical inactivity, we realize that they contribute to 30% of your risk of developing dementia. Yes, all these things that we can do something about, the modifiable risk factors, account for only 30% of our risk. In fact, these 4 at the top, which we will refer to as non-modifiable, account for 70% of the risk. So let us take a minute to address one of the most important questions that was asked. What are some of the early signs of dementia? We mentioned that people, as they grow old, continue to have their normal mental functions. But a few persons will begin to experience a decline in their memory or in their thinking, abstract thinking, and so on. But that is normally not severe enough to interfere with their quality of life. These decrements might be noticed by others. And when they go to the doctor is usually able to identify that, yes, there is some memory impairment, there are some cognitive changes, but you're doing very well. That is a condition we call mild cognitive impairment. Every year, 40% of persons with mild cognitive impairment will regain their normal cognitive function. A significant portion, however, annually will become demented. But we are increasingly finding out that a certain subset of persons with mild cognitive impairment will remain with mild cognitive impairment for decades and will never become demented and will continue to have mild cognitive impairment. And so, as we think about awareness of dementia, we really want to pay attention to these early signs of cognitive changes long before the person is demented. The development of this concept of mild cognitive impairment, which is about 25, 30 years old, developed by Ron Peterson and others, has helped us to begin to intervene earlier in the treatment of persons with a family history of dementia who begin to show signs of cognitive impairment. Because we anticipate that those with a family history who are already showing signs of impairment are more likely to become demented. And to the extent that you intervene early, you're able to prevent them from becoming demented, or at least you may decline the rate of their deterioration. You may reduce the rate of deterioration. But over the past 5 years, we have begun to realize that there are certain behavior changes which seems to predate even the cognitive changes. And we now understand that these behavior changes are even greater predictors of developing dementia than the cognitive changes. And we have started to label them as mild behavioral changes. So to the question of what are the early signs of dementia, we can now say that behavior changes in an older adult may predate cognitive changes and may be a greater predictor of developing dementia, and it certainly appears to be an earlier appearance than the cognitive changes. So if your loved one is beginning to show changes in their behavior, you need to be aware. And this is where the whole question of awareness that Delaney and Shireen and Rika spoke about is very important. Because unless you are aware that these behavior changes may predate dementia, you'll do nothing about it. While early intervention in persons with these behavior changes and in persons with these early cognitive changes may actually prevent them from developing dementia. It is interesting that there is an overlap between persons with early behavior changes and early cognitive changes. And that subset of persons are at significantly greater risk of developing dementia, and they demand early and urgent intervention. Please don't try to understand this slide. I'm simply trying to show you that there are certain things that develop in the brain. At the top line, that orange line of beta amyloid deposition, 0.0 on the lower horizontal axis is the point at which the diagnosis of dementia is made. So we can see that 30 years before the diagnosis of dementia, beta amyloid begins to be deposited in the brain. And the green line is CSF, cerebrospinal fluid tau, another substance that is deposited in the brain. That also begins to be deposited 2 to 3 decades before the person is diagnosed. At the bottom, we have glucose metabolism, which is the energy formation in the brain, and energy production in the brain begins to decline up to 2 decades before the person is diagnosed. So many of the changes which ultimately lead to dementia occurs 2 to 3 decades before the point of diagnosis. It gives us, therefore, enough time, if we are aware and suspicious, to identify the early signs and possibly to intervene and to reverse the process. So we spoke about the mild behavioral impairment as some of the early signs of impending dementia. What are these behavior changes? Changes in appetite, nighttime behavior, unable to sleep at night or excessive sleeping, motor disturbance, irritability, apathy. Apathy is a serious predictor of impending dementia. The person who has been active and involved who is no longer interested in anything. Depression, anxiety, delusions, aggressiveness or agitation. These are some of the very early signs that we need to look at to say, listen, if our parent or our loved one was not like this, and this is a drastic change from what they were, they seem to remember very well. So what is going on? You need to be aware that these may be a predictive sign of impending dementia. The good thing about it is that if you intervene and treat these changes, in many cases, you're able to prevent a deterioration. And this is so important that I've included a checklist of some of the early behavior signs, which you can find at www.mbitest.org. You Google it and you will have a wonderful questionnaire checklist that you can use to alert you. On this checklist, you'll see questions like, is the person tearful? Has their mood become low? Are they less able to experience pleasure? Do they talk about feeling as if they're useless, worthless, and that they're a failure? Are they talking about being a burden to the family? Do they become impulsive, argumentative, temperamental, disinhibited, very happy, shouting? These are some of the things that will be included in this questionnaire. It's an excellent questionnaire. I invite you to Google www.mbitest.org and download a copy. It is free. In Jamaica, at the Alzheimer's Disease Outreach Program, we have listed 10 of our top early signs. The first one is recent memory loss affecting the job. In other words, the person is still at work. So we're talking about persons in their 50s and 60s. They may be at the top of their game. And yet, simple things that they would normally do is now becoming problematic. And what do? They will ask a subordinate to do it. Subordinate would then end up feeling very good that the boss has now asked me to do this. So he or she finally recognizing my work. Mom would normally cook dinner for Persia or for Christmas or whatever, or for Thanksgiving. And now she's asking me to do it. And we need to ask ourselves why. Why is the person now asking us to do things that they would normally do? And that is because they're having difficulty performing familiar tasks. They may develop problems with language, and this is particular for persons with Alzheimer's disease. A person with vascular changes, language tends not to be a problem. They may have disorientation in time and space, decrease or poor judgment, problem with abstract thinking, forgetting things and misplacing things beyond what they normally would experience, change in mood or behavior, change in personality, and the loss of initiative. These last three are really behavioral signs which tend to occur long before most people get suspicious. And these are some of the ones that we really need to pay attention to. Okay, the next question that we were asked to look at is the whole question of caregiving. Now, the patient is always at the center of any caregiving exercise, but the environment in which the caregiving is conducted is important. An environment in which there is overstimulation, too much noise, too many people running around, too much talking, too much activity, can lead to agitation in the patient. It's just impossible for them to deal with all that information. But the most common thing is understimulation. We feed them, we come back later and we change them, we pass back 2 hours later and we feed them again, and we're doing a good job, but there's no stimulation, and after a while, they become agitated. You want to have a structured environment. You want to make sure that they are safe. You want to establish routines. You want to have bath time at the same time, activity time at the same time, and so on and so forth. They may not remember, but they are able to identify that this is the time that I normally have breakfast. This is the time that I normally would take a bath. The other problem is that most patients with dementia begin to get agitated when they have unmet needs. What is it? Am I hungry? Am I thirsty? Are they in pain? Usually you do not have a rapid decline in their mental function because of the Alzheimer's disease or because of the dementia. A rapid change in their mental state is normally due to a physical factor. In my experience, a urinary tract infection, joint pain, constipation, or hunger. These are the major factors that we need to look for. Pay close attention to those family members and friends who are visually or auditorily challenged. It means that they have less stimulation, and therefore they need more touch, which may be a massage very often throughout the day. Every time you pass them, you touch them on and you may ask, how are you doing or whatever. Just let them know that you are there and you care for them. But what about the caregivers? What determines caregiver burnout? Well, as Shireen mentioned, most of our caregivers are women. Most are daughters and daughters-in-law. But we do have some sons who are caregivers. Now we have immediate hands-on caregivers. We have family caregivers, we have professional caregivers. And in most cases, we have a combination of both. We may have a family member who's the main caregiver, but there's some paid assistance. And then we may have family members who live close by, who offer emotional support. This is extremely important. And then we have a family member who lives abroad, who sends home money regularly. They offer financial support. That is also important. And then we have the brother who lives next door who will help to do the gardening or do the repairs to the house. So caregiving demands support from all aspects. And all these areas of support are equally important. However, the primary hands-on caregiver comes under significant stress, and they need as much support as they can get themselves. What we have found is that the primary determinant of caregiver burnout is one, the level of support, and two, the level of education of the caregiver. Most caregivers may think that the only outcome is that you get burnt out. But we have caregivers who enjoy caregiving. And these are the caregivers who have been trained to understand the specific dementia that they're dealing with, because all dementias are different. And training allows you to preempt the needs of the patient, to understand their behavior changes and how to deal with these changes. A common behavior in dementia patients is that they want their mother. I want my mother. And because we want them we want to educate them and we want to correct them so they don't make the mistake again, we say, well, you know, your mother died 35 years ago. And then they start to cry and shout, and we don't know why. They're crying and shouting because you have just told them for the first time that their mother died. That is something that you never do. If they want their mother, then agree with them that, yes, you know, I also want to see mom. Let us plan to go and look for her. In doing that, you validate their desire and they would tend to calm down. The next thing we deal with regularly is the desire that they want to go home. Again, we want to set them straight by telling them that you have been living in this house for 50 years. Never do that, because you're telling them that they're fools. You have been living here and you don't even know how stupid can you be. No, we validate. Yes, I want to go home too, let us plan to go home. Let us have a glass of lemonade. Let us have some tea. And then later on, when it's cooler in the day, we will go home. Once you validate them, they will calm down. And because of the memory impairment, they will tend to forget until tomorrow. But why? Why do they want their mother? Why do they want to go home? Because things are not normal where I am. Because I feel threatened. Whenever I feel threatened, I want my mother. Someone hits you, you want your mother. Now I'm in a home, I don't recognize the place where I am, so it's not my home. So in both cases, they need more hands-on attention, more love, more care. So those are some of the main things I wanted to say about caregiving. Caregiving is very serious work. Caregivers need great support, both financially, emotionally, and physically. But you should never underestimate the type of support that is given by the person who is not there, or by the male family member who might not deal with the hands-on issues, but will come and do the lifting and the home repair and so on. Sometimes the caregiver needs a respite, because a caregiver who's burnt out will not help the patient, and the patient quality of patient care will deteriorate. So caregivers need to identify when they can no longer cope. Now, even in the best of conditions, there comes a time when it is not possible to safely continue to manage your loved one at home. How do you know that the time is right to consider a nursing home placement? That's a very, very difficult question, because we all start out by saying, listen, we want mom and dad to stay at home, because that is what they told us they wanted. But when you reach the point where you begin to question, well, this is my mom or this is my dad. Listen, this is not how my mom would behave. This is not how my dad would behave. The minute you begin to dissociate yourself, then you know that it is time that you seriously need to look at a nursing home placement. So we mentioned that these 7 modifiable risk factors for dementia account for just 30% of the risk. And that these 4 factors of age, family history, of this lipid transporter protein, apolipoprotein E, in your blood, and your gender accounts for 70% of your risk. And that these 4 factors are non-modifiable. So on the face of it, we can't do anything about it. And here at Without Filters, we have always tried to do the impossible. So in the next couple of minutes, I'm going to try and look at these unmodifiable risk factors to see what lies behind them. And is it possible that we, in fact, may be able to modify them? So, age is by far the most important risk factor for dementia. Every 5 years, the prevalence of dementia doubles. So why is it that age is such a major risk factor? Today, we believe that 2 processes predominate in your brain as you get older: free radical proliferation and inflammation. And these factors interfere with the genetic material and your gene expression, resulting in conditions that are conducive to the formation of precipitates in the brain, such as beta amyloid and tau, leading to various types of dementia. Free radicals are electrically charged atoms or molecules or substances. When they enter the body, they can cause disruption to your DNA. Free radicals are formed in the body normally, and we use them to fight germs. We use free radicals to neutralize viruses and bacteria. But when free radicals are produced in excess, they begin to attack the normal cells. They enter the nucleus of the cells and interfere with the gene expression. So exposure to excess ultraviolet light is a common source of free radicals. In Jamaica, we do a lot of deep frying of everything using vegetable oils. And I'm convinced that this is the main source of free radical formation. And when we eat the foods that are fried in these vegetable oils at high temperature, the food now mixed with the free radicals enter your body and become part of the cell membrane. The cell membrane becomes permeable. The free radicals enter the nucleus, and that's how the process begins. Air pollution, pesticides, insecticides, excess alcohol consumption, exposure to ionizing radiation are all common free radical producers. Diabetes is a free radical producing condition, as is excessive exercise, continuous stress, smoking, and excess metabolism. What is excess metabolism? That is what takes place in people who overeat. The more you eat, the more metabolism takes place in the mitochondria, and the more free radicals are produced. We now know that periodic starvation, where you reduce your food intake, can extend your life by 30% simply by reducing the level of metabolism and the production of free radicals. So these are some of the things that we need to be aware of as sources of free radicals. The normal body has free radicals being produced, but it also has something called antioxidants, which are the antidotes to free radicals. So a healthy body would have enough antioxidants to neutralize the free radicals. ROS means reactive oxygen species, which are free radicals. So a young brain tends to have enough antioxidants which would fight against the free radicals and minimize the inflammatory process in the brain. As the brain gets older, the amount of free radicals the amount of free radicals increase and the amount of antioxidants decreases, so there's an imbalance. The excess of free radicals lead to increased inflammation in the brain, resulting in Alzheimer's disease, cancer, osteoporosis, age spots in your skin, age-related macular degeneration, diabetes, and many other conditions we have now established are due to these increased free radicals which promote inflammation. In the brain, we actually have a system which is the brain's own antioxidant system to neutralize free radicals. Essential for that process is vitamin E, which reacts with the free radicals to neutralize it. For the vitamin E to be reactivated, you need vitamin C and you need the B vitamins. So immediately we see that if you want to protect your brain adequately, you need enough vitamin E, vitamin C, and the B vitamins. And we have discussed the other things. So let us now look at family history, because we have looked at age and we have seen that age is a risk factor because of the proliferation of free radicals and the increased inflammatory process. What about family history? Well, family history has to do with your genetic makeup. There is early onset and there is late onset Alzheimer's disease. Both are connected to various genes. So the early onset Alzheimer's disease is associated on chromosome 1, 14, and 21. that is presenilin 1, 2, and the amyloid precursor protein. And then the late onset Alzheimer's disease is associated primarily with chromosome 19, which is the apolipoprotein E. Now, apolipoprotein E, we will discuss a bit later on, is extremely important in explaining the increased risk of dementia in our women. So I want you to look out for that. So in the brain, these amyloid precursor protein are usually metabolized. They are spliced into small pieces. In the process, depending on the enzyme which splices the amyloid precursor protein, you may get some insoluble particles. And these insoluble particles may precipitate in the brain and lead to conditions such as Alzheimer's disease. Let us imagine that there are two young people, one with the gene for the early onset Alzheimer's disease, and the lady without the gene. She has a normal gene which would not predispose her to Alzheimer's disease. The young man has no signs of Alzheimer's disease. Granted, his father might have had dementia at 60, but they are young and they're beautiful and they love each other. Well, if they have offspring, each child has a 50% chance of acquiring this dominant gene for Alzheimer's disease. So there's a 50% chance that each offspring will develop Alzheimer's disease. But let's imagine that both young, beautiful people have parents with the gene for early onset Alzheimer's disease. They are beautiful, they are young, they look very well, they are intelligent, and they don't ask questions about their parents. Well, each offspring has a 75% chance of acquiring this gene and of developing Alzheimer's disease. So it goes to show that you really want to question your lover about many things. So why is this gene important? As I mentioned, the amyloid precursor protein is, when it is metabolized, is spliced by certain enzymes. Normally, it is spliced by alpha secretase and gamma secretase. When it is spliced by enzyme A and alpha and gamma, the results are insoluble particles. These are soluble particles which are removed from the body, so they are not toxic. However, when amyloid precursor protein is spliced, not by alpha secretase, but by beta secretase outside of the cell, then the result is a unit called beta amyloid with 42 amino acids, which is insoluble. This precipitates in the brain and causes Alzheimer's disease. So the reason why the people with the gene for Alzheimer's disease develop Alzheimer's disease later on is because this enzyme, the beta secretase, is being produced in excess instead of the alpha secretase. It also explains why these persons with the gene do not develop Alzheimer's disease at 20 and 30, because at that age, alpha secretase is still active. Why then does beta secretase become active, or why does alpha secretase become inactive as we get older? And that is an interesting question, because that determines whether or not you develop Alzheimer's disease, regardless of whether you have the gene or not. This is a cartoon of what a gene looks like. One section of the gene at one end codes for protein, let us say for the enzyme alpha secretase or gamma secretase or beta secretase. The other end of the gene is the promoter end, which is able to actually turn off the gene. So the fact that you have a gene for a condition does not necessarily mean that you will develop that condition. all you need to do is to turn off or turn on the gene. Now, it appears that when these persons are young, the gene for alpha secretase is turned on, and the gene for beta secretase is turned off. But as they get older, for some reason, the gene for alpha secretase is being turned off, and the gene for the beta secretase, which is a dangerous enzyme, is being turned on. How then can we ensure that as we get older, the gene for alpha secretase continue to be active and the gene for beta secretase continue to be inactive? We have identified that there's a change in the genetic structure at a certain point where the nucleotides undergo mutation. Usually you have a certain collection of nucleotides. You have a AT, TA, CG, CG. However, one area of cytosine guanine is converted to adenine thymine area. And that leads to the deactivation of the alpha secretase. Now, this process occurs normally in everyone. However, the younger brain has the ability to correct the conversion, the flipping over, can be reflipped back to normal through a process called methylation. It appears that this process slows down as we get older. Now, what are the requirements of methylation? For methylation to continue to be active, we need a diet that is rich in folic acid, vitamin B2, B6, B12, magnesium, and vitamin D. This slide is important. This slide allows us to keep the Alzheimer's disease genes turned off, whether we have them or not. So if we continue to take in high levels of these substances, vitamin B2, B6, B12, folic acid, magnesium, and vitamin D, as we get older, then we are able to keep the alpha secretase enzyme active and minimize the risk of developing dementia. Studies have also shown that persons who take a statin drug for cholesterol may also find that this alpha secretase level increases and the beta secretase level decreases. So it appears that the statin level, the consumption of a statin drug can help to deactivate the formation of beta amyloid. And this is interesting, especially for persons with a family history of dementia. And this might even be relevant regardless of your cholesterol level. What about gender? Shireen mentioned that a significant number of deaths in persons with dementia occur in women. In fact, women have a 2-to-1 risk ratio of developing dementia. And we have thought about this. Why are women more at risk of developing Alzheimer's disease specifically? Is it because they go through a lot of hormonal changes during pregnancy? Is it because they like to do shopping and they spend a lot of money? Is it because they used to spend a lot of time in the kitchen, but not anymore? We don't know. What we do know is that women, being female, have an independent higher risk of developing dementia. Today, we're beginning to realize that women are known to be more likely to possess a certain fat-carrying protein in their blood, which predisposes them to Alzheimer's disease. This is called the apolipoprotein, which carry lipid in the blood Now, there are different variants of the apolipoprotein E. And the genes normally occur in pairs. So you can have apolipoprotein 2, 3, or 4. So you can have 2E3, 2E4, or 2E2, or E3 and an E2, E3 and E4, and so on. And your risk of dementia depends on the combination that you have. But those women with, or those persons with 2 apolipoprotein E3 genes, they have no increased risk of Alzheimer's disease. Persons with an apolipoprotein E3 and an E2 have 50% risk or a 40% reduction in their risk of developing dementia. Those with 2 apolipoprotein E2 also have 50% reduced risk of dementia. But those who have 2 apolipoprotein E4 have 15 times the risk. So this one seems to be the dangerous one, apolipoprotein E4. Those with 2 E4 will have 15 times the risk of the dementia. Those with 1 E4 and an E2 will have almost 3 times the risk. And those with 1 E4 and an E3 will have 3 times the risk. Now, it appears that E4 is more common in women, and that this explains the increased risk of dementia in women. Now, apolipoprotein E4 leads to a lot of problems. It reduces the metabolism of lipid and cholesterol. It reduces the production of energy. It destroys vascular function. It interferes with the clearance of beta amyloid from the brain. It reduces the formation of new nerve cells. It reduces glucose metabolism and synaptic function, causing increased brain atrophy, neuronal toxicity, aggregation of both plaques and tangles, and so on. So apolipoprotein E4, which is more common in women, is toxic to the brain and explains why women are at greater risk of developing dementia of the Alzheimer's type. Now, what do we know? We now know that women who keep their cholesterol levels below what is considered normal. So normal is a low of, say, 5.2 millimoles per liter. If you keep it around 4 or even 3.5, you remove the risk that the E4 provides, regardless of whether or not you have that apolipoprotein E4. So you can remove your risk of dementia as a female by keeping your cholesterol levels relatively low. And this is a major breakthrough for women. What about diabetes? Well, diabetes has long been known to increase your risk of dementia by at least 30%. It appears that most diabetics have a condition which is called insulin resistance, which increases the formation of beta amyloid plaques in the brain, destroys the function of the synapses, and lead to the accumulation of all those end products associated with dementia. Insulin resistance seems to be the main problem with our diabetics as a risk factor for dementia. And there are many studies that show that this insulin resistance interferes with the production of energy in the areas of the brain which control memory, which is the hippocampus. Interestingly, using coconut oil bypasses the normal insulin mechanism because of the formation of ketones, which can also be used to produce energy. So coconut oil is a good alternative to energy production in the brain in persons with dementia. And I recommend that we use coconut oil regularly. So, in all, when we look at the processes that increases our risk of dementia, we see that free radical proliferation, inflammation, impaired methylation, hyperinsulinemia, a deficiency of certain vitamins and high cholesterol level at midlife are some of the main pathogenic processes. How do we deal with them? We need a diet that is rich in antioxidants, and that we get from fruits and vegetables, nuts and grains. Melon is a strong source of antioxidants, so we want to increase the amount of melon in our diet. What about turmeric? Strong anti-inflammatory and antioxidant properties. We want to increase the use of turmeric. We want to increase the use of ginger. Lemongrass also has strong anti-inflammatory and antioxidant properties. So we want to use lemongrass tea, and we want to use it in our rice and so on. In Jamaica, we have a hibiscus plant called sorrel, which makes a wonderful drink, has also excellent properties to prevent dementia. Moringa is available all over the world. It too has properties of lowering your blood sugar, reduces inflammation, and acts as a good antioxidant. So we want a diet that is rich in omega-3 fatty acid, which we get from fish, olive oil, fish oil, nuts, and grains. These fish sources are excellent for omega-3 fatty acid, which we know is the strongest antioxidant in nature. So mackerel, herring, sardines, tuna, very readily available, inexpensive sources of fish and of omega-3 fatty acid. Salmon, herring, and sardine, if you're worried about mercury levels. And so omega-3 fatty acid will increase your good cholesterol. It reduces your blood pressure, reduces the risk of dementia, reduces insulin resistance and inflammation, reduces your triglyceride levels, your platelets adhesiveness, and increases omega-3 good properties of anti-inflammation in the body. This plant is known by anyone from Sri Lanka. It's a native Sri Lankan plant. That we'll ask that question later on in the question and answer section. So let's summarize what we have discussed so far today. Dementia is an increasing problem worldwide. Over 55 million persons today are diagnosed with dementia, with a new case every 3 seconds. We have identified the risk factors of dementia as being anything which affects your brain from childhood onwards. So you want to protect your brain, not just when you're old, but when you're young. You want to be aware of dementia so that you can identify the early signs. We have identified some of the early signs as being behavior changes and not just cognitive changes. Apathy, irritability, restlessness, nighttime behavior, change in appetite are some of the things that should alert us that this person may be going towards dementia down the road. We now know that if we intervene very early, we might be able to stop the process. The environment in which we live is important. Exposure to insecticides and other toxic substances may determine whether or not, regardless of our genetic makeup, whether we develop dementia or not. Women, being female, is an independent risk factor because the apolipoprotein E gene tends to be more common in women. But we can remove this risk by keeping the cholesterol level a little below what is considered normal. The use of a statin drug, regardless of your cholesterol level, may also be useful in removing the risk for women. Antioxidants can help significantly in keeping your brain young. We have said that the methylation process slows down as you get older, primarily because we are no longer consuming as much vitamin, folic acid, vitamin B2, 6, B12, magnesium. And so a lot of the good genes which help to turn off the bad genes are affected. So we can change this process by beginning to eat more antioxidants in our diet. Hyperinsulinemia interferes with the metabolism in the brain and energy formation, and we can reduce hyperinsulinemia by exercising regularly and by taking a drug called metformin, which is now being understood to be extremely good in preventing certain age-related problems. Free radicals and inflammation are serious factors on the age as a risk factor. So if you want to age without the increased risk of dementia, you want to control inflammation and the free radical proliferation in your brain. Caregiving is serious business. It does not have to be painful. The more educated about the illness you are, the better it is to cope. You can be a caregiver and leave the process feeling satisfied that you have done a good job. For this to happen, you need enough outside support emotionally, financially, and physically. But you also need to train yourself about the particular type of dementia that you're dealing with. I want to thank you very much for your attention and look forward to any questions that you may have. Back to the moderator.
Thank you, Albert. So I'm opening the floor up for questions. Can you hear me?
Yeah, we can hear you, Dilni. We are just waiting for people to unmute and ask any questions if they have. Shireen, would you like to ask anything?
Excellent presentation, Albert.
Thank you, Albert.
Excellent.
Thank you. Very, very expensive and excellent. Yes, thank you. What I'd like to ask is things like yoga, where there is a lot of mind-body the process of the mind-body, the thinking through all those aspects. Am I muted?
No, we're hearing you clearly.
Hi. Yeah, so I'm just thinking on like, introspection and lifestyle behavioral changes. Has that been researched through in any form for mitigating dementia and the processes that we discussed?
Yes, I think so, because when we think about a healthy brain, we're also thinking about stress management and so on, and yoga and these other mind-body modalities have been shown to reduce cortisol levels in the body, and cortisol, which is increased because of the stress of life, contributes significantly to a lot of the changes which occur in the brain due to stress. So I believe that the yoga, meditation, and other mind-body modalities can contribute significantly to dementia prevention. We're talking about health, right? And the more physically healthy you are, is usually the more mentally healthy you are. And it's not wise to separate physical from mental health. So exercise, yoga, meditation, all these things contribute to good health, both physical and mental health.
Horace, you had a question?
No, just commenting the excellent presentation, Albert. Excellent. I certainly have learned a lot. And really thankful. I'm glad I joined this.
Okay, thank you, Horace.
I have another question to ask. It's about fresh vegetables and fresh produce. I mean, how fresh is fresh now? Because the apples are like transported from Chile or from New Zealand. It's wax coated. So, you know, we eat a whole apple, but how much of nutrition are, because the best form would be either animal or vegetable source. But that said, it's laced with all the possible toxic elements. And then again, we are preserving them. So how much of that can we identify as nutritious?
Well, I think anecdotally, we can assume that persons who produce vegetables on a commercial scale are going to use both commercial fertilizers and insecticides and so on to maximize their production. We have a different interest as consumers, and we have to be wary of this. On the other side, when we talk about folic acid and vitamin B2, B6, and B12 as being extremely important to protect your brain, a lot of these vitamins we get from fresh fruits and vegetables. So on the one hand, we want to consume more fresh vegetables and so on. But on the other hand, these vegetables may also pose a problem because they are not as wholesome as we think. How do you deal with that? I think going forward, we're going to have to go back to the backyard gardening or the rooftop gardening and so on, and the pot gardening and the flower pot gardening where you can grow your vegetables. I think that's the only way we're going to be guaranteed that what we're consuming is of good quality. We can be assured that if the vegetables we buy are produced commercially, that they have a lot of insecticides and pesticides in them. We can be assured of that.
Thank you.
I am also, if I may add, I am also not sure that the usual advice that you wash your vegetables in a little warm water or so, if that is enough. I am not sure if that is enough to get rid of the pesticides and insecticides in these vegetables. In Jamaica, we have the farmers, the Rasta men. They say that if there are no worms on the vegetables, you shouldn't eat it. Because if the worms don't want it, why should you want it? You know, and that's something that we should look at. These fresh, nice, beautiful, clean looking vegetables may not be that wholesome after all.
My question to you is that, you know, if you feel that you have the early signs of dementia, in this era of specialization, which doctor should we approach and raise our concerns? I mean, you know, these days the medical fraternity expects you to decide the specialty and go. So how should we approach, or which doctor should we approach? That's a confusion.
No, it's an interesting question because you're right. You're expected to know the right person to go to.
Yeah.
I think you want to have a very good general practitioner with whom you have a certain history. They understand your condition, and you explain. You're normally comfortable with your general practitioner to explain your symptoms and allow the general practitioner to decide. But the broader question is, who deals with dementia? And there's a big fight between the neurologist and the psychiatrist. And as a gerontologist, I will tell you that the gerontologist is the best person to deal with dementia. In Jamaica, we find that a lot of people go to the psychiatrist. I don't consider that to be a very wise idea. I think if you have a good neurologist, you should go to a neurologist. If you have a geriatrician, you should go to the geriatrician. If you have a clinical gerontologist, I think those are the best options. I think the psychiatrists tend to look for psychiatric problems to treat without looking at underlying issues that may be treatable themselves, which may not be psychiatric problems.
Right.
But
Yeah,
And if I may add, Albert, there is no other corroborations, be it radiology or any other diagnostic methods that psychiatry uses other than blood work, right? Neurology has imaging that they would refer to. Psychiatry
That's
doesn't
right.
tend to go with that. Am I right?
It is unbelievable that the psychiatrists are not sending their patients with mental illness for MRI of the brain, because everything is in the mind. Where that is, I don't know. So we treat the mind, and therefore we end up using antipsychotic medications as the first choice, which is not something we want to do in dementia.
To digress,
So
since you're talking on that, I just want to add that SPECT scans are ordered by psychiatrists when they have criminals, when they have to go in for court cases. That's when a SPECT scan is ordered. That's done. That's about the only imaging technique that I've heard of.
yes, yes. And that's something we speak to our psychiatrists about, and they always promise that, okay, we're going to pay more attention to the structural changes. But in truth, that's not their forte. They deal with that area that we are unable to identify, called the mind. And we don't understand it. They understand it. But the end point is that your patient with dementia end up being prescribed antipsychotics more frequently when they visit a psychiatrist than when they visit a neurologist.
I
Or
think
other
Renee is asking, is there a diagnostic test to detect dementia?
Yes, the dementia, you see, the term dementia is a global term which indicates that your cognitive functions have declined to a certain level. It doesn't say why. So the diagnostic tests are really not to determine whether you have the dementia, but to determine what is the cause. And this is important because some causes are treatable and some are not. Some causes are reversible and some are not. Imagine that someone has a dementia that is due to a deficiency of, say, vitamin B12, which is theoretically reversible. And you begin to give them medication to improve their memory and antipsychotics without dealing with the deficit, which is a vitamin B12 deficit. So you need to identify the cause of the dementia. The term dementia is never a diagnosis. It is just a definition of a point in your cognitive life where you are no longer able to cope. Doctors are always going to try to identify why. So we have screening tests such as the mini-mental status examination, the MOCA examination. There are a lot of screening tests for dementia, which gives you an idea if you have a problem. But after that, you now need to identify what exactly is the problem, how severe is the problem, what can be done. So the MOCA and the mini-mental are two very common, and they are online. You can get examples of them. But your general physician can normally conduct these screening tests for you, and that will give them an idea if they need to do further checks. And they may decide then to refer you to a specialist. If you suspect that you're having a problem, you should go to your general doctor. Never sit down, as I've mentioned, if some of the early signs are addressed, you can prevent continued deterioration and worsening of your cognitive function in some cases. At least you might be able to slow down the process. So don't assume that it's just, I'm tired or I need some more rest or so. Have it checked out, see what's happening, and that's my advice.
One comment before I go, Albert. I think a lot of emphasis needs to be placed on the caregivers as well, to ensure that they themselves don't end up in that situation.
Yes, all right. So caregiving is serious. It's very serious business. And especially when only one person is involved, it can be very difficult. And sometimes the caregivers themselves take on too much because they love the person involved and they want to do everything for the person. And so their life now becomes only about this person and they forget their own issues. Yeah, so caregivers need care. Caregivers themselves need care.
Renee, would you like to ask your question? I can see that you are unmuted.
Yeah, I wanted to actually miss the part where you spoke about when exactly, after the behavioral change and all that, when should a patient be relocated to the nursing home when the caregiver is not able to give or do anything more for the patient? And the children need to be told about this. Like you gave the example of where usually parents tell their children that please don't put us in a nursing home or an old age home. But there will come a time for a patient suffering from dementia when probably they need more help than the caregiver can give at home. So what are the signs that the children should look out for?
Well, the example I gave is when you reach the point where you begin to dissociate yourself from the person. In other words, this is not my mom. My mom would never do this. No, this is not my father. My father would never curse like that. That is usually an indication that you have reached the limit. And I recommend that even though you want to adhere to the wishes of your loved one, that it might be necessary at this point to seriously consider nursing home placement. Most persons will continue to take care of their loved ones at home until the end, and that is commendable. But if you find that you're no longer associating yourself because this person's behavior is so different from that we were accustomed to, then then it's usually a sign that it's time.
Oh, okay. Yeah, thank you. Thank you so much.
I have 3 questions. The first is, can there be self-awareness or a self-assessment when there's a cognitive decline? I mean, it's pertaining to dementia. Number 2 is, has there been cases of early onset? Now we are talking of 60 and above or 70 and above, but have you in your clinical practice come across an early onset of dementia? And the third question was, I forget, I'll let get my mind on that.
Yeah, that normally happens when we talk about dementia. We always forget something.
I had to remember my 3 questions.
It will come back. It will come back to you.
Now that means, am I coming for? I now know it. Geriatrics and gerontology. Is it the same or is it different? So I don't need to see Albert. I'm fine now at this point in time.
But you needed to take a break. All right. So it's a very interesting question because there appear to be differences in the level of self-awareness depending on the cause of the dementia. Early in the dementing process, people with Alzheimer's disease, persons with even Lewy body dementia, or persons with Parkinson's disease dementia may begin to understand that something is wrong. And they are normally much easier to get along with because there's some level of acceptance. The biggest problem we have is with persons with vascular dementia. They tend not to have a major memory problem. What they have is problem with executive function, planning, execution, and so on. But they seem to have lost the ability to accept or to be aware of their condition. So they believe they are cognitively normal. So they keep forgetting things and then they will never accept that they forget. So, and then they lie, and we tend not to call it lying. So these persons will say, leave the kettle on the stove, and you saw them light the stove, and you saw everything, and then you say, Mom, why did you leave the kettle on? And Mom will say, well, I didn't put the kettle on. Because they can't recall putting the kettle on. And so they answer your question by thinking and asking themselves, is this something that I would normally have done? Would I have put on the kettle and walk away? And so we call it confabulation, but it creates a lot of problems because the caregivers and the loved one know that what they are seeing is correct, but the person who is affected will not accept it. And it's a major challenge with persons with small strokes in the brain. The other thing we notice is that not only are they unaware and they become very paranoid, because if you keep talking to them about their memory, they think that their memory is fine. It means that you're trying to get them. Okay, so they become very paranoid and aggressive. They get very concerned about money, my money, which is their money, right? And that can create a lot of problems. So self-awareness is possible, but is less likely in the persons with small strokes. Early onset, we see very, very regularly here in Jamaica. Lewy body dementia tends to start a little earlier than Alzheimer's disease, in the late 50s and early 60s. So a person in the early 60s or late 50s who is already demented is normally affected either by Lewy body dementia or early onset Alzheimer's disease. But there are some other conditions. I have a patient who's about 46 now, who's fully demented. Yes, and this has nothing to do with either Alzheimer's disease or Lewy body. So there are different conditions which may cause early onset dementia, and we see it very, very frequently.
If I may, I think severe depression from
The third
young,
question was about what again? Can you remind me of that one?
that's the one about gerontology.
And geriatrics.
Oh, right. They are similar. The geriatric deal primarily with the clinical issues. The clinical gerontologists deal both with the clinical and the social issues.
What I was saying is that severe depression from a young age can lead to early cognitive dysfunction, right, Albert?
All right. No, our experience with depression is this. People who have had repeated episodes of depression throughout their lives do not necessarily have a significant increased risk of dementia. But persons who become demented, depressed for the first time in their 50s and 60s are usually at increased risk, because in this case, the depression is usually an arbiter or a predictor of a dementing process. But repeated episodes of depression also appears to increase your risk, but not as significantly as the person who becomes depressed for the first time in their 50s and 60s. I hope that answered the question.
Thank you. And traumatic brain injury, especially among the boxers and the footballers.
Right. So as I mentioned in one of the slides, usually there are multiple hits to your brain. Exposure to insecticides. I reminded Shireen about the time she fell off the guava tree at the back of Ladies College. All of those things contribute to what happens later on. And the outcome might not be Alzheimer's disease. It might be Parkinson's disease. It might be some other outcome, but you will have to pay the price later on.
Thank you. Any other questions? If you'd like to thank Albert
Yeah.
again. Sorry.
I think this has really kept us, I mean, is going to keep us thinking for quite some time, and, you know, trying to see if we are having any of these signs of dementia. I think this is going to engage us and occupy us for quite some time now. Thank you so much, Dilini and Dr. Albert, for this wonderful session. I mean, you have raised our awareness on dementia and the ways to prevent it, as well as the concept of caregiving. So really, heartfelt thanks to you. Thanks to you. both.
Albert, for again assisting our group. I appreciate the second year now, and hopefully next year we can do this again.
Yes, absolutely. Yeah.
And the
welcome.
next year, we will use the new DSM definition of it. We'll park dementia and we'll get a little more savvy with the DSM term. Now I've forgotten it. Short-term memory challenges.
Rekha has recorded the session.
Yes,
so
I will send the link to Shireen so that she can send it to you all. Yeah.
I upload it on YouTube. I can share the link once it's uploaded.
great. Thanks again, everyone.
Thank you again.
Thank you very
And,
much, Albert and Dilini.
yeah, and we'll see everyone in the next month. Shireen, do you want to announce the next month?
Yes, we are having wellness. We are commemorating the mental health. We are kind of keeping the month's commemoration, which is mental health. And we are having a physician who's in holistic healing from England in October. So, Albert and Horace, please do join.
Thank you. We will.
Bye.
Have enjoy your Saturday.
I'm stopping the recording.
Okay. Bye. Bye. Thank
Bye.
you.
Thanks.